finding or understanding, which is that tricuspid valve relates to systemic venous connection or flow. And systemic venous connection or flow is of low pressure. So minor differences, very minor differences, can be considered quite important. So when we call mild mitral stenosis to be a gradient of 5, maybe mean of 7, on the tricuspid side, the mean of 7 is already very severe tricuspid stenosis. It's no more a mild or even a moderate, because any gradient on the tricuspid side more than or equal 3 millimeter mercury, mean gradient more than or equal 3 millimeter mercury, would become quite important. And definitely any gradient 6 millimeter mercury or above becomes actually severe. It is very important when we talk about pathophysiology to relate it to few things. You have noted from the previous 2 talks that we are always relating it to hemodynamics, to the chamber that is affected by that lesion, to arrhythmia and effect on rhythm, and to effect on the body and the rest of the organs. So it is quite important to understand such pathophysiology and consider the related structures always to the lesions we are talking about. The lesion we are talking about, which is the tricuspid valve, relates to the following structures: the right atrium, the SVC and any venous drainage above it, the IVC and any venous drainage below it, and the interatrial septum, plus the right ventricle. So let's take first what would be the pathophysiological effect on hemodynamics caused by tricuspid valve stenosis. If we talk about tricuspid valve stenosis, which is mild, gradient less than 3 millimeter mercury, then for sure the effect on the right atrial hemodynamics would be a mild rise in right atrial, SVC, and IVC pressure. What is a mild rise? A normal mean right atrial pressure will be around, let's say, 6 to 8 millimeter mercury, maybe more towards 6. So if you add another 3 or less, you will have a mean of 9 or a mean of 10 on the right atrium. A mean of 10 or a mean of 9 on the right atrium, as we all know, and we can see from practice and experience, that it usually does not lead to significant hemodynamic change, because it does not affect the capillary pressure in the organs affected by or draining into the right atrium. Let's talk about the brain. What is the gradient between the arteriolar pressure and the venular pressure across the capillaries of the brain parenchyma? It is about 15 millimeter mercury. We talk about 25 arteriolar mean pressure on the arterial system in the brain, and about 10 in the venous system. So the difference is 15. If we raise the pressure in the SVC or in the jugular vein because of a rise in the right atrium because of the tricuspid valve stenosis, which is only mild, and we said the rise is only 3, then the venular pressure will be around 12 to 13. Venular pressure 12 to 13 will make the transcapillary arteriolar venular gradient become, instead of 15, becomes 18. We know your arteriolar pressure is a mean of 25. So it can still overcome it. Have you grabbed that clearly? If I rise the right atrium pressure by 3 because of mild tricuspid stenosis, then the S superior vena cava internal jugular pressure has risen, ارتفع, by another 3. We said there is a mean venular of 10, so the mean venular will be 13. If the mean venular is 13 with a mean arteriolar of 25, the difference is now reduced from 15 to 13 because the gradient now has risen to 18. And why the gradient raised to 18? Because of the higher venous pressure. And 18 is still a pressure that the brain can perfuse by, because the arteriolar is 25. So we do not expect mild tricuspid stenosis to affect the internal jugular artery venous drainage or hinder any brain venous drainage. Same wise, the arm and the rest of the upper body will not be affected. So this is the superior vena cava. What else is connected to the right atrium if its pressure rises? What is connected is the IVC with hepatic veins coming in and the rest of the IVC. Again, the same rule apply. We know that the wedge hepatic vein pressure, if we take a wedge pressure in the hepatic veins, the normal mean is around 6 millimeter mercury. If we take a hepatic vein wedge pressure, normal mean inside the liver is about a mean of 6. So if we raise the IVC pressure because of the rise in the right atrial pressure, because of the tricuspid mild stenosis, then we expect a mean wedge to go from 6 to 9 because of that increase of 3. Again, 9 millimeter wedge is not that high to prevent hepatic venous flow from going back to the heart, because still the IVC pressure or the portal pressure even can go by like 13 or 12. It's not going to be extremely high as a venous pressure, and hence we on the hemodynamic part on the right side we do not see any significant hemodynamic effect by tricuspid mild stenosis, neither on the organs drained by the superior vena cava or the organs drained by the inferior vena cava. So this is for mild tricuspid stenosis. What is the effect of mild tricuspid stenosis on the right atrium? Do we see any significant right atrial dilatation? No, obviously we do not see any significant right atrial dilatation, and because of that we will not see any significant arrhythmia, any significant atrial arrhythmia, mainly atrial flutter or atrial fibrillation, because the right atrium is not significantly dilated and the conduction through the right atrium is not interrupted, and we do not form any of those abnormal disconnected circuits that leads to flutter or fibrillation. Up to now, things are clear. I'm going to look at your comments. Ahmed, are you guys following and things are okay and clear?
بالنسبة لي كلير إن شاء الله.
تمام. Okay, so come on. Yes, clear all. تمام دكتور. تمام. So this is for mild. Do you expect any other effects from mild tricuspid stenosis? What if there was a patent foramen ovale? What if there is a patent foramen ovale in the interatrial septum? Do we expect an effect of mild stenosis like right to left shunt, like Ahmed is saying? Well, we said the mean pressure will go from, let's say, mean of 6 goes to mean of 9 or 10. Do you think a right to left shunt will occur? Probably unlikely. And probably we will see no desaturation. Why? Because the mean left atrial pressure is usually higher, but not that high. Let's say it's a mean of 8 instead of mean of 6 on the right, normal. So a difference between mean of 8 and mean of 9 or mean of 10 will not cause any significant right to left shunt. So we do not expect any desaturation from a PFO in the presence of mild tricuspid valve stenosis. The other thing, do we expect any blood stasis? Do we expect clot formation on the right side? No, obviously no. Why? Because the blood will still be flowing easily into the RV and actually being sucked by the RV through the mild stenosis without hindering the flow to the extent that it causes any blood stasis. So there is no blood stasis. We do not expect clot formation from mild tricuspid valve stenosis. Okay, let's see what's the effect on cardiac output. Would the cardiac output be compromised because of mild tricuspid valve stenosis? No, the cardiac output will not be compromised because the right atrial mild elevation of pressure will overcome the tricuspid stenosis, and the RV will have good filling pressures, good filling volume, and the cardiac output will not be affected. طيب, tricuspid valve stenosis, does it affect the right ventricular volume? So can we see any signs of smaller RV or hypoplastic RV, or the RV getting smaller with prolonged tricuspid valve stenosis? Obviously, when it's mild, no, we do not see that. The cardiac output is going through very easily. So mild tricuspid stenosis does not have any significant hemodynamic, cardiac output, structure, arrhythmia, thrombogenicity or thrombus formation, desaturation or right to left shunt. We do not see it with mild tricuspid valve stenosis. طيب, let's go now to moderate tricuspid stenosis. And obviously, whatever applies to moderate tricuspid stenosis will apply definitely to severe tricuspid valve stenosis. Moderate valve stenosis, the gradient is probably anything between mean of 4 to mean of 6, less than 6, more than 4. Obviously, here we have a significant gradient, although it sounds very small. Yes, mild tricuspid stenosis is asymptomatic and requires no treatment. You don't need to do anything about it. You just need to follow it maybe once a year just to make sure it's it's not getting worse. Okay, so let's go now to moderate. If we say there is a mean of 4 to 6, let's take 5 as a number. Mean of 5, if the mean in the right atrium is 6 and there is tricuspid stenosis mean of 5, the right atrial peak pressure will become at least 11. Do we agree? So 5 plus 6, it's 11. And if the mean is 8, then the peak is 13. Here, we are obviously going into higher pressure. If I tell you a patient, you have a patient in the ICU, and I tell you the mean CVP pressure is 11 to 13. Is that high or no? That's high for sure. It is significantly high. So let's go back and do the same exercise like we did with mild. Now let's see the organs which are being fed or are actually draining into the SVC, draining into the IVC, and see what this mean gradient will, how this mean gradient will affect them. If we have now a mean of 5 on the tricuspid valve and the peak pressure in the right atrium is now 11 or 13, just take in the middle, let's say 12. Mean of 12 in the SVC. So the venular mean will go up. We said it's usually normal of 10. If we add now the 3 or sorry, the mean of 5 on it, it will become mean of 15. We said that the transarteriolar, transcapillary, arteriolar to venular is normally 15. Now we have a venular of 15, and the pressure in the arteriolar does not change. It's still 25. So to drive blood through the brain capillaries, the driving force is a mean of 10, isn't it? It's 25 arteriolar. Now we have almost a 15 on the venular side. It's the driving pulse pressure is 10. That's quite low. To drive through the capillaries easily, you need a good 15 pressure gradient. Now it has dropped. Before it was 12, 13 with mild. No, now it has dropped to 10. 10 will definitely cause some venous stasis in the organ affected. So the brain, if it's subjected to such higher venular pressure, on the long run may develop chronic brain edema. Nothing acute, nothing that will cause dysfunction significantly, but it will develop chronic brain edema, and with all the effects, headache, fatigue, somnolence, and so on. So you see, we went only from mild to moderate. The same if you go back to the liver. If you have in the liver, which we said the venous hepatic vein wedge pressure or normal is mean of 6, and now we have another gradient of 5. If we add that to it, it will become 11. So inside the portal vein, inside the IVC, the mean pressure is usually 6, 9, maybe 8, but now it has to overcome an 11 pressure or higher. So again, we will have some liver stasis, and the liver gets affected very easily with elevated venous pressure. It will not cause anything acute. You will not see, let's say, significant hepatic dysfunction liver enzyme derangement, hyperbilirubinemia, liver dysfunction. No, it will not go to that. But if you leave it for a longer time, you can start developing some liver cirrhosis. And because now we have a mean of around 11 to 13 or 12 in the RA. That's why for a Fontan, what is a good pressure for a Fontan? What is a pressure that we like the Fontan to have? Anyone can answer? I'm listening. What is the mean pressure that you like to see in a Fontan circulation? Less than 15 for sure. And that's why you don't want any higher pressures. You see, it's 15 is not so much different from 10, but this extra 5 you add makes a huge difference. That's why a moderate tricuspid stenosis can start giving you some organ dysfunction. Not severe, but it starts if you leave it for a long time and not treat it. Obviously, we will start seeing some right atrial dilatation with moderate tricuspid stenosis. We will start, if there is a patent foramen ovale, we will start seeing a right to left shunt because now we have a mean right atrial pressure of around 12 or 13. The mean pressure in the left atrium maximum will be around like mean of 8, mean of 9. There's a good gradient now, 5 to 6, which will cause a right to left shunt and may cause some desaturation. So the right atrial dilatation we see, is it severe or mild right atrial dilatation? Usually it is mild to moderate right atrial dilatation. And that's why with moderate tricuspid stenosis, we mostly do not see any significant arrhythmias or blood stasis or clot formation in the right atrium. The cardiac output will still be continued. The right ventricle will still be filled because the atria still can overcome this stenosis by getting the pressure slightly higher to mean of 12 and overcoming the stenosis. طيب. When it becomes severe, which is a mean of 6 or above, then we have problems with all what we talked about. Then you can have significant brain edema with time. This is, we're talking about lesions that develop over time, not acute severe tricuspid stenosis. Like somebody, let's say if somebody has a sudden clot that develops on the tricuspid valve and it becomes acutely stenotic, then the symptoms are actually severe and acute. But we're talking here about things that build up gradually, and it gives time for the liver, for the brain to dilate, to become more edematous, to enlarge, and not acute. But so we will see chronic changes, not acute changes. So in severe, we will see significant brain edema and with all the effects. We will see significant liver congestion with hepatomegaly, possible liver enzyme changes. If you leave it for longer, you'll start seeing liver fibrosis. You leave it for longer, you can see liver cirrhosis and liver failure if it's left so long with no decompression. We will see right atrial dilatation, which is quite significant. We can see arrhythmias, especially atrial flutter and fibrillation, significant arrhythmias. The cardiac output, if there is no patent foramen ovale, will be affected, and there will be right-sided congestion and even symptoms of systemic low cardiac output state. So you will have what looks like right-sided failure hepatomegaly, lower limb edema, ascites, facial edema, brain edema, liver congestion. And if you leave it for longer, you start seeing some fatigue, exercise intolerance, all signs of low cardiac output. So you can see clots forming, smoke in the right atrium. Definitely, if there is a PFO, there will be significant desaturation because the right to left shunt will be quite significant. So that's why when we treat tricuspid valve stenosis when it's moderate or above. And when it's moderate, we can treat it medically, mainly by diuretics. When it's severe, then the treatment is no more medical. It needs either surgical repair or interventional repair. Type. So this is one obstructive lesion that we talked about, which is tricuspid valve stenosis. Any questions before I move to the other lesion? I am going to talk in the next few minutes about right ventricle outflow tract obstruction, and then I'll follow it by the aortic and then the mitral, inshallah. Any questions? Okay, good. So let's move to the pathophysiology of right-sided right ventricular outflow obstruction. Now I'm sure you are aligned with me in the way how we look at things and how we think. Right-sided obstruction, we talk about subpulmonary stenosis or pulmonary stenosis or peripheral pulmonary stenosis. These are all causes of right ventricular outflow obstruction. Let's talk about what is the normal RV pressure. What maybe something like anything between 18 to 25 systolic with a diastolic and diastolic pressure of anything between 3 to 6. So that's a normal RV pressure. If we add mild RV outflow tract obstruction, whether sub-PS or PS or peripheral, how high would the RV pressure go? What is a mild gradient in the subpulmonary area considered? Probably anything like a peak of 25 to 30. That's probably considered mild. On the pulmonary valve, anything less than 40 is mild. On the peripheral pulmonary branches, probably 30 or less is considered mild. So if we have a gradient of, let's say, let's choose a number, let's say choose 25, and then we add it to a normal pressure of 20, then RV pressure becomes 45. What do you think about an RV pressure of 45 systolic millimeter mercury? Obviously, it is elevated, but if you look at the systemic pressure in a child who has a blood pressure of around 80 systolic or 90, then it is almost half systemic or less than half systemic. We all know if your RV pressure is half systemic or less, you can do quite well. And most of the time you are asymptomatic and you don't need much things to go for you. So a mild right ventricular outflow tract obstruction. Let's go now again all the points we discussed, structure-wise, would it cause any significant right ventricular hypertrophy? Obviously, no significant right ventricular hypertrophy. Maybe mild, maybe only detected by ECG, but obviously by echo, I'm not sure you will be able to detect any significant size change or hypertrophy on the right ventricle. Okay, so would it affect the cardiac output? Would the RV not be able to pump the cardiac output in mild obstructive lesion of the right ventricular outflow tract? Obviously, no, because the right ventricle still has the capacity, volume, and pressure-wise to pump the cardiac output to the lungs and to the left heart eventually. So cardiac output is usually not affected. Okay, so what's the effect on arrhythmia? Nothing much, because there is usually no dilatation, no hypertrophy of the right ventricle, and no affection of others. And I will talk about what do I mean by others. طيب, any effect on the endothelium of the right ventricle? Like, can we see fibroelastosis? Obviously, no, because the pressure or the wall tension on the RV wall and the coronary supply is not hindered by the slightly elevated RV pressure, because the end diastolic pressure usually in mild RVOT obstruction remains normal, so that your endocardium will be well perfused by coronary flow from the myocardium to it without being really affected, and hence we will not have significant RV fibrosis or fibroelastosis. Any effect on the pulmonary valve? Like, let's say we have subpulmonary stenosis, let's say RV, double chamber RV. Any effect on the pulmonary valve when it's mild because of the jet effect? You see, when you have stenosis below the valve, there is a jet shooting from the RV on the leaflets. Can it injure it? That's possible with time, but because the gradient is low, because the RV pressure is low to start with, usually there is no significant pulmonary valve leaflet involvement in the disease, and unless there is pulmonary stenosis, not subpulmonary stenosis, and you will not see any pulmonary valve leaflet thickening. You will not see pulmonary valve regurgitation more than the usual trivial to mild, which is normal. And would you see any main pulmonary artery dilatation? Anyone can answer this question? This is a quiz question. سؤال اختبار. In mild pulmonary valve stenosis, can you see main pulmonary artery dilatation or no? يلا, who will answer عشان نخليه شوية interactive بدل ما هو كله كلام. No. No. Any other answers? Any other takers? I have 3 no's. طيب. The answer is actually yes, you can. It's not a must, but you can. You know why? Because the main pulmonary artery wall is usually normally quite thin. Any jet effect on it can give you main pulmonary artery dilatation. So main pulmonary artery dilatation in the presence of pulmonary valve stenosis specifically has no relation, no significant relation. Is it severe or moderate or mild? You may have severe pulmonary valve stenosis with only mild main pulmonary artery dilatation. You may have mild to moderate pulmonary valve stenosis with very significant main pulmonary artery dilatation. So main pulmonary artery dilatation does not go into the criteria of how we evaluate right ventricular outflow tract obstruction unless it is quite dilated. And you have to always think pathophysiologically, if it's quite dilated, especially with mild pulmonary stenosis, that actually you may have elastic or elastin tissue disease, connective tissue disease, congenital connective tissue disease affecting those. And there is quite a relationship between pulmonary stenosis and connective tissue disease, like in Ehlers-Danlos, like in William Allison disease, like in tortuosity syndromes. So stenosis can come with dilatation because of elastin tissue problem, regardless of significant gradient. Okay, if we have now pulmonary stenosis, whether it's subpulmonary or peripheral or valve, would it affect the right atrial pressure? Yalla, who will answer? Would it affect the right atrial pressure? Yes. One answer. طيب, I'll ask you 119 to everyone. When is it going to do that? When is this yes? Yes, if moderate to severe, Ahmed Fawzi. So the answer, yes, it can, but it will only do that when the right ventricular EDP, end-diastolic pressure, is high. It will not do it when the end-diastolic pressure is normal. And you will not see end-diastolic pressure change with mild or moderate pulmonary or right ventricular outflow obstruction. You will not see any of that. EDP will change with chronic or prolonged severe obstruction of the right ventricular outflow tract. Then the EDP goes higher, maybe it will reach 12. The right atrium then will become 14 or 15, and we see an effect that looks like tricuspid stenosis. So more like severe outflow obstruction for a long time can cause increased right ventricular end-diastolic pressure, and then you can start seeing obviously effects of increased right atrial pressure. Right. Okay, so let's go now to arrhythmias. Do we expect any arrhythmias with mild obstruction of the outflow tract? Obviously no, because there is no dilatation. Do we expect? Yes, you are right. No. Do we expect any blood stasis in the right ventricle? Obviously no. Do we expect any right to left shunt if there was a VSD in the interventricular septum? Obviously no, because the right ventricular pressure is still much lower than the left ventricular pressure. So in mild outflow tract obstruction, there is no symptoms. There is minimal hemodynamic effect. Cardiac output is good. Arrhythmias are not there. Chamber dilatation or hypertrophy is not there. So we'll go to moderate outflow tract obstruction, whether it is sub-PS or PS or PPS, peripheral pulmonary valve stenosis. Let's take sub-PS. Gradient now, instead of being 30, the gradient now is around 40 to 45. And obviously your RV pressure now, if it is gradient of 40, it's no more 45 like in mild. The RV pressure now is around 60. If you have a blood pressure of 90, that's slightly more almost 60% of systemic pressure. So here, moderate pulmonary valve stenosis, the RV pressure, which was normally 20, is now going to be 60, 3 times. Now you should see some changes. Let's take it from backward to upward or to front. Atrial pressure, will it be affected? No, usually, because the EDP, even if it's prolonged and it's only moderate stenosis, the EDP in the right ventricle will not be affected. طيب. I missed to say also we should check tricuspid valve regurgitation when we have outflow obstruction. So mild will not cause any significant tricuspid valve regurgitation. Moderate, if you already have mild tricuspid valve regurg, it may become mild plus, but definitely it would not become moderate. So EDP does not enlarge or increase in subpulmonary stenosis, which is moderate. Right ventricular hypertrophy can start happening, and we can have mild RVH, but definitely no RV dilatation. Do we see any RV endothelial fibroelastosis or fibrosis? No. Arrhythmias, also we don't see any arrhythmias. Stasis or clot formation in the RV cavity? Obviously, no. Arrhythmias, extremely rare, very unlikely to happen. So obviously, not much of a hemodynamic effect. Cardiac output will be great. So what's the effect now on the pulmonary valve itself? Now we have sub-PS. Now you can start seeing, because it's moderate, you can't start seeing some, if it's close to the valve, you can start seeing pulmonary valve thickening and maybe slightly more pulmonary regurg. This does not mean we need to do anything about it because it's still moderate and not causing anything to the cardiac output, not causing any significant RVH, arrhythmias, clots, limitation, symptomatology. So again, we don't do, but we have to understand the pathophysiology, because when we follow patients with moderate and they start showing signs of a pathophysiology of severe, even if the gradient looks moderate, then we treat them as if they are severe. Let's say you have a moderate subpulmonary stenosis, and the patient is a baby and he has a PFO. The PFO was almost all the time shunting left to right because the right atrial pressure did not increase. But suddenly he comes to your clinic and now the baby is slightly desaturated, slightly cyanosed. And you take a pulse oximeter and his SAT is like 92 or 93. You look at the echo, there is some occasional right to left shunt, but your gradient is saying it's only moderate stenosis. Now, because of this added criteria, which has changed with time, you can no more consider that this is a benign lesion. This is now becoming a lesion with starting effect or complication. So that's why the pathophysiology is so important to understand when you are evaluating a cardiac patient. طيب. So moderate pulmonary valve stenosis, again, the same as moderate subpulmonary valve. طيب. What about moderate bilateral PPS? If you have a gradient of 40, no more a gradient of 30, a gradient of 40, 45 on the LP, the left pulmonary artery, and the right pulmonary artery. Here it is different. Moderate bilateral, not moderate unilateral, can give you a severe effect on the right ventricle. So if you have a gradient, let's say, of 40 on the left pulmonary artery, a gradient of 40 on the right pulmonary artery, what would be the pressure? What would be the pressure in the right ventricle? Yellow. Who can tell me? Yalla guys, an answer quickly. It would be RV pressure of at least 60, at least. And actually, it may be 80. It may be 80. You add the gradient here to the gradient there, 40 plus 40, 80. So 60 to 80. And you can see why is that? Because now the two outflows, the two lungs are obstructed. So a moderate bilateral pulmonary artery stenosis is not equal to a moderate pulmonary valve stenosis or subpulmonary valve stenosis. It may be slightly worse. That's why when bilateral PPS is moderate to severe, we treat it. And we only treat severe pulmonary stenosis and severe sub-PFs. We don't wait for a gradient of 70 on a left pulmonary artery or a right pulmonary artery to intervene. We usually intervene from a gradient of 50 and above. Although for a pulmonary valve in a child, not in an adult, we want at least a gradient of 70 in average to go and do, let's say, pulmonary valve balloon dilatation. So definitely there is difference when you have bilateral PPS, moderate to severe, compared to moderate valve stenosis. So moderate, again, does not cause much cardiac output limitation, no arrhythmias, hypertrophy, yes, increased, thrombus formation, no, maybe pulmonary valve thickening if it was sub-PFs. طيب. Now we go to severe. Severe sub-PFs is a very significant disease. And when we say severe, the gradient is actually 50 to 70. That's already severe. It's not like the valve is 70. 50 to 70 sub-PS is already a severe gradient. And it can cause right ventricular hypertrophy. If it is left for a long time, it can give high right ventricular end diastolic pressure. If it's left for long, it can cause RV systolic dysfunction and diastolic dysfunction. It can cause right atrial high pressure if left untreated for a long time. And with all the effects, except for the cardiac output. The cardiac output, even in severe sub-PFs, will always be maintained if we do not have severe tricuspid regurgitation, which can happen with severe obstruction. If we have severe tricuspid regurgitation, then the cardiac output may not be maintained. If we do not have systolic dysfunction, then we will not have significant stasis or clot formation. Arrhythmia, even in severe sub-PS, is a very rare phenomenon, unless it is severe sub-PS left for years and years. We talk about years and years, yani definitely more than 5 years, more approximating left for like 8 to 15 years untreated. That's why you see it in the late presenters. Okay, so what else do we see? Any RV fibrosis, fibroelastosis? Yes, if it is left for a long time, you can see more of that. Can we see pulmonary valve damage because of sub-PS? Yes, if it is severe, we can see moderate or even more than moderate pulmonary valve regurgitation because of the jet effect of such a lesion. So severe sub-PS can have significant pathophysiological effect, except for cardiac output, usually it does not cause much, and for arrhythmia, usually it does not cause much difference unless there is significant tricuspid valve regurgitation. The pulmonary valve regurgitation, if it becomes moderate, usually also it will not add significant pathophysiology. But treatment-wise, usually these patients, if their right ventricular function is preserved, systolic and diastolic, even if it's severe, usually these patients are asymptomatic and they do not need medical therapy, but definitely they need relief of the RVOT, most likely surgical. طيب, pulmonary valve stenosis, we talk usually in a child with a gradient of 70, not 50 to 70 like the sub-PS. That's where we consider it severe. Again, it's almost like the sub-PS in the effects if you leave it for long time, right ventricular hypertrophy, longer time, right ventricular dysfunction, systolic and diastolic. Cardiac output is usually well maintained, even in severe sub-PS, if we do not have significant tricuspid valve regurgitation. Arrhythmia is very unlikely in severe PS unless it is left to be a complicated severe PS. What do I mean by complicated severe PS? I mean by that right ventricular dysfunction and the presence of significant tricuspid valve regurg. When is the cardiac output affected in pulmonary stenosis? Can somebody answer that? When there's a question there, pulmonary valve damage is only a regurgitation? Yes, in terms of function. In terms of structure, the valve will be more thickened, more nodular if you leave it for a long time, but effect on function is definitely regurg. It does not cause pulmonary valve stenosis because of substenosis. طيب. So who can answer me a question? In which level of pulmonary valve stenosis we can start seeing loss of cardiac output? Who can answer? In RV dysfunction, but I'm talking about the level of obstruction. What do we call this, Ahmed? لا, level is level, I mean يعني amount, not level. We're still talking about pulmonary valve. When does the cardiac output is become affected in severe pulmonary valve stenosis? When does it become affected?
Critical base.
Yes, when you go to critical. So what are the criteria to call somebody that he is having critical pulmonary valve stenosis? Give me pathophysiological criteria.
انه يبقى في تكريس في الفلو، وانه يبقى عنده بي دي اي عليها ليفت رايت شنت، ان هو دكت ديبندنت، ويبتدي ديسات.
Okay, but this is the PDA is only to improve the saturation. You have nothing to do with it. Before you go to the PDA, how do you call somebody that he or she is having critical pulmonary stenosis? What's the hallmark of it? You said RV
dysfunction.
Dysfunction. This is one criteria. What's the other criteria? Desaturation, Dr. Rula said, for sure. So let me say it in a different way, Dr. Rula. it is actually right to left shunting on the atrial level. If you see somebody with severe PS and he's shunting right to left, then you have to know that this could be now becoming critical. So what is the third criteria? Significant tricuspid valve regurg. The cardiac output cannot go through this valve. That's why we call it critical, isn't it? مظبوط؟
تمام.
تمام. So significant tricuspid valve regurg. What else? One more.
ممكن لو الفلو نفسه بين هول او
Yeah,
مينيمال
okay.
فلو على
So
البلمونري.
extremely limited flow across the valve. You have a high gradient, but at the same time, the flow is very low. And this is now critical pulmonary valve stenosis. This has its own pathophysiology. So we'll see severe cyanosis, signs of low cardiac output, right-sided failure possibility, atrial arrhythmia if it has developed not acutely but over time, like somebody who had severe PS, but we let it go until chronically over time to critical, you start having the arrhythmias, you start having the clots, but differentiate that between the chronic one and the critical neonatal one. Like somebody is suddenly born with severe critical PS and the ductus is closing. That's totally different. There, you don't see arrhythmia significant, you don't see clots, but you see signs of severe cyanosis and low cardiac output. طيب. So that's the critical part. So severe pulmonary stenosis can give us significant right ventricular hypertrophy, can give us arrhythmia, very unlikely. Cardiac output is usually still maintained even in severe. Tricuspid regurg may, if it was mild, may become mild to moderate. If the right ventricular function is preserved in severe PS, then usually the child is asymptomatic at rest and asymptomatic even with moderate exercise. But with significant exercise, no, the child will become symptomatic and will not be able to maintain good cardiac output. Okay, so I think we've said enough about right ventricular outflow obstruction. These are and about the tricuspid valve. These are two lesions which are on the same side but are different. One deals more with diastole, which is the tricuspid valve stenosis, and all the effect of a high venous pressure, and the other one deals more with systole and all the effect of RV hypertension. تمام؟ مش pulmonary hypertension, RV hypertension. The I sometimes see echo reports for tricuspid regurg gradient, and then it's high, and then they call it pulmonary hypertension. No, you cannot call it pulmonary hypertension unless you have assessed the right ventricular outflow and the branch PAs. If it is all clear and open and the pressure is high, then this is pulmonary hypertension regardless of the cause. But if the RV pressure is high in the presence of pulmonary stenosis, this is RV hypertension because the PAs are protected. They have nothing to do with pulmonary hypertension. And sometimes, you mean in a newborn? Yes, I mean in a newborn. Critical pulmonary stenosis is acute because suddenly the child goes from fetal circulation to neonatal circulation. The valve is closed. He needs his ductus. You will see severe desaturation, low cardiac output, but you will not see arrhythmias or clots unless it was severe and left for a long time in life, and then it happens. Okay, طيب.
معلش بروف
any
سؤال. لو
أحمد
يونيلاترال بريفرال بي اس الار في بريشر بتحسب ازاي؟
علي صوتك يا أحمد.
لو يونيلاترال بريفرال بالمونري ستينوزس.
طيب. Okay, so unilateral it's good that you mentioned that, because bilateral is usually the one that gives you the pathophysiology. What if this is obstructive lesion, unilateral, let's say left pulmonary artery stenosis, but the right is normal, and there is no pulmonary valve stenosis, and there is no subpulmonary valve stenosis? Usually, let's take it one by one. Cardiac output, will it be affected? No. Why no? Because we have at least one good lung taking the cardiac output. Let's talk about right ventricular pressure. Will it be high? Usually, again, no, it will not be high. And if anything, it can be mildly to moderately high, not even moderate, yani full moderate, mildly to moderate. But usually, it will also be normal. And we will also see no right ventricular hypertrophy, no arrhythmias, no sluggishness. Cardiac output is okay. End-diastolic pressure is good. But all of that is not important. There is more important things. Why does that happen? Before we go to the important thing, why does that happen? Because the normal lung will take over the function of the stenotic lung. So if you have mild unilateral pulmonary, peripheral stenosis, nothing is expected to be of abnormal pathophysiology, because even the lung that has the mildly stenotic pulmonary artery, left or right, will be well perfused. We will not see any loss of cardiac output to that lung. Moderate pulmonary, peripheral pulmonary stenosis, unilateral, will also have no significant pathophysiology, neither on the right ventricle, cardiac output, or on the lung with that stenosis, because it will still be well perfused. What do I mean by well perfused? A lung is well perfused even if it receives 30% of the cardiac output. Normally, your right lung receives about 60%, your left lung about 40%, because the right lung is larger. A left lung with a left pulmonary stenosis is still okay, even if the percentage of cardiac output that goes through it is down to 30%. So it's only when we have severe peripheral pulmonary artery stenosis, unilateral, that we see pathophysiological effect on the affected lung. On the heart, usually we see nothing, because the other lung will compensate. Occasionally, the other lung does not compensate, and there is high resistance on. And this is quite complicated. Let me leave it until I finish first the unilateral. So what would happen with severe unilateral? The pulmonary artery itself, if it has stenosis, distal to the stenosis, the pulmonary artery will become normal size or hypoplastic? Anyone can answer? It will become small because it is underfilled. So if it is underfilled, that lung can become smaller or hypoplastic or not, especially if the stenosis was very early in life or in utero. Definitely you may have lung hypoplasia, especially if this peripheral pulmonary stenosis unilateral started early in life, mainly in utero, like what we see in scimitar syndrome. Usually the right pulmonary artery is smaller and the right lung is actually also smaller. Type. Then we will have poor perfusion of one of the lungs, and it can go to the extent that actually, because of severe unilateral peripheral pulmonary stenosis, that you can actually lose completely that branch pulmonary artery. It may totally occlude or become atretic. طيب. this is the usual, that unilateral peripheral pulmonary stenosis, even if severe, does not affect the right side. But remember always, and this is not the usual, not the common, but it can happen. Can you have peripheral pulmonary stenosis unilateral and RV significant hypertension? The answer is yes or no. The answer is yes, you can. Why is that so? Why? Why there is RV hypertension? The right lung is supposed to be carrying the cardiac output. It can't take it. يلا يا أحمد, why?
الرايت لانج هتبقى هايبرتنسيف
ليش طيب؟
عشان عليها اوفر فلو، يبقى الماي فاسكولار ريزيستنس يعلى.
That's a possibility, but it's a rare possibility. يعني usually the right lung can get larger with time to accept all that flow. But it is a possibility. بالذات لو كان في additional left right shunt. يعني لو واحد عنده pulmonary stenosis ومعاها ASD، يعني branch pulmonary artery stenosis ومعاها large ASD في cardiac output زيادة, you may say that. But the usual cardiac output without a left right shunt, it's unlikely for the right lung to be hypertensive just because of the normal volume. Although it is a known phenomena and it can happen, but rare. And if it is going to happen, it may happen on the long run. يعني أكثر من 10 15 سنة you leave such a person like that. عشان كده في transplant, let's say في cardiac transplant, if you transplant to one lung, which can happen, the risk of developing pulmonary hypertension is definitely higher than if you transplant into two lungs. But it is not that high. It is a rare happening. طيب, give me another cause. Why? What happens in the abnormal lung when it is poorly perfused? What neurohormonal or neurovascular effect does severe unilateral branch pulmonary stenosis have, or has? Actually have, because I said does. You see, if the lung is poorly perfused, it immediately wants to increase its filling pressure. So what it does, it actually goes into vasoconstriction. That lung become vasoconstricted, trying to increase the perfusion pressure. Reflexly and through neurovascular reflex, the other lung may start to become also vasoconstricted because of the reflex action. And this can actually give you the other lung hypertension and RV hypertension. This is a very rare happening, but you may find it sometime in a patient if you follow and you strangely find this patient has moderate to severe or severe branch pulmonary stenosis unilateral, but the RV pressure is high. Why is it high? The other lung looks good. So why is it high? It must be that the resistance in the other lung is high. معلش يا دكتورة هنا ما فيش صورة لأنه يعني أنا بدرس من وسط البيت وكده فاعذريني. طيب، والكمبيوتر معلش حتى كمبيوتري أنا ما اشتغل اليوم، أخذت كمبيوتر ثاني في صورتي الشخصية في الكمبيوتر الثاني، هذا كمبيوتر ولدي. تمام. طيب, so if we go back to that, if you find a patient with branch pulmonary artery stenosis and starting to develop RV hypertension, you have to start questioning that the other lung now is affected. Is it affected because cardiac output is going through it and it's developing true high resistance, or is it a reflex resistance? That's something else. With treatment will become quite different. This is very advanced pathophysiology. I don't think you have to worry about it now. طيب, We have been talking now for about 1 hour and 20 minutes. You think we should stop, Ahmed, and leave the left side for another session?
زي ما حضرتك تحب.
والله أنا أفضل عشان المعلومات حقت الرايت سايد يعني تستوعب كويس، ونرجع in another session for the left side obstruction، لأنه فيها كلام أطول بكثير من اللي أنا قلته على الرايت سايد. وأيضا بعد كده إن شاء الله نكمل وناخذ الريجرجيتنت ليجنز برضو رايت لوحدهم وليفت لوحدهم.
تمام ماشي حاضر.
تمام. احنا ان شاء الله يعني داخلين على رمضان، فكل عام وانتم بخير جميعا. نسال الله يتقبل منا ومنكم صالح الاعمال. لا تنسونا جميعا، كل واحد ما ينسى الثاني من الدعاء. واسال الله سبحانه وتعالى ان يجعله علم نافع وعمل صالح. ويعني all of us should really يعني try to benefit from each other and spread the knowledge. انا ما عندي مانع يكون عندنا كمان محاضرة في رمضان if it's fine with you، يعني بعد التراويح ما عندي اي مشكلة، نرتب ان شاء الله خلال اسبوعين من الان. طيب، جزاكم الله خير وشكرا جزيلا وحفظكم الله. شكرا يا احمد.
تمام ان شاء الله. معلش يا بروف، انا كان عندي سؤال.
هات.
سؤالين معلش.
ولا
اول
يهمك.
سؤال، السوبرا فالفولار بالمونري ستينوزس
ايوه.
ممكن يبقى دايليتد باي بالون دايليتيشن ولا لازم سيرجري؟
usually it's a big failure with balloon dilatation، الا اذا انت مره مضطر. لو واحد عنده severe right ventricular dysfunction ومش عارف توديه لجراحه وخطر على الجراحه وعنده مشكله كبيره، you can try a balloon، بس حتى في البالون ممكن يموت منك. ف probably no, it is not a disease that responds to balloon dilatation, although there are reported cases. بس ما هو المين treatment. No, so the answer is no. And it's also not a disease for stenting. Why?
تمام.
Because you can damage the valve. The indication of balloon or stenting in suprapulmonary valve stenosis are very limited in very specific situations. So the answer is no. You go is somebody with significant supravalve stenosis, he goes for surgical repair.
طب والانديكيشن للبريفرال بي اس سواء يونيلاترال او بايلاترال، امتى بعمل بالون دايليتيشن؟
هذه محاضرة لوحدها يا أحمد. أنت عندك حوالي 6 7 8 indications، كل واحدة تفرق. خليني أقول لك هي بسرعة، ويمكن مرة من المرات ناخدها يعني كواحدة من المحاضرات فيما يقدم إن شاء الله.
تمام.
So when do you interfere in peripheral pulmonary stenosis? The answer when the peripheral pulmonary stenosis is severe. We do not interfere if it is not severe. What's the definition of severe? هذه اللي فيها كلام طويل. Severe can be a gradient of equal or above 55. تمام? Severe can be a diameter which is Z-score in the severe area. Severe can be limited echo Doppler flow. Severe can be poor perfusion of the lung, 20% or less on a nuclear scan. Severe can be presence of RV hypertension. Severe can be presence of RV dysfunction. You see how many indications, Ahmed?
ما شاء الله. وبزيد حضرتك.
So, and we can talk like this even longer. There are other severe things. So I hope I answered you. يعني هو severe. When it's severe, you intervene. How to judge severeness? It's different. تمام.
تمام. جزاك الله خير، كل خير. كل سنة وحضرتك طيب.
الله يحفظك.
ألف شكر لحضرتك.
يلا شكرا جزيلا، السلام عليكم جميعا.
وعليكم السلام ورحمة الله وبركاته.